Hello everyone, my name is Modi, and today we're going to present this case presentation with my colleagues Sultan Al-Qahtani, Ghada Yusuf, and Wujdan Muhammad. General data, age 30 years old, gender, male. Chief complaint, discomfort in the maxillary right area. The patient thinks it could be the sinus related. History of present illness, discomfort in the upper right area. Past medical history, he has undergo prosthetic valve replacement surgery 1 year ago. Past dental history, multiple restorations on tooth number 16, 46, and 47. Family history not mentioned. Habit history not mentioned. Clinical examination not mentioned.
Hello everyone, my name is Sultan Al-Qahtani. I will continue to talk about the radiographic interpretation. The type of radiographic projection, there is two types. The first one is a pre-apical view, and the second one is CPC MH1 and MH2 is taken from a different angulation. And as you see here in the X-ray, the tooth number 16, there is a large restoration and radiolucent lesion encroaching the sinus area. Location and site and number of the lesion. It's located in maxillary right side on posterior region, the epicenter at the apex of the tooth number 16, and it is unilacular and solitary. The size and shape, it's approximately 30 mm times 13 mm, and it is a round shape. The extent. Its extent, superior inferior extending from the root apex to the sinus, and the bitterframe border, it's well-defined cortical border. And the internal structure, it's a radiolucent. The effective surrounding structure, loss of lamella dura and widening of PDL space around the root, and expansion of cortical border. The last is encroaching a maxillary sinus.
Hello everyone, my name is Ghada and I'll continue talking about the differential diagnosis. First, radicular cyst, odontogenic keratocyst, periapical cemental dysplasia in early stage, and simple bone cyst. First, radicular cyst, clinical feature, most common type of cysts, male more than females, arises from non-vital tooth, teeth that have lost vitalities because of extensive caries, large restoration, or previous trauma. No symptoms unless secondary infected, may cause swelling, 3 to 6 decades of life. Radiographic features, the epicenter is at the apex of a non-vital tooth, most common seen in the maxilla, in incisor and canine region. Well defined with cortical border. Secondary infection may result in the loss of the cortical margin or alteration of this cortex into a more sclerotic border. Internal structure is radiolucent and sometimes with dystrophic calcification in long-standing cysts, may cause displacement and resorption of the roots, may invaginate into the antrum, cause expansion of the cortical border. Histological feature, the cyst is lined with stratified squamous epithelium. Mucous cells or areas of ciliated pseudostratified columnar epithelium may be noted. Odontogenic keratocyst, clinical feature, 1/10 of all cysts in the jaws, second or third decades of life, sometimes arise around unerupted tooth, males more than females. Aspiration may relieve thick, cheesy, creamy material. No pain or discomfort unless secondary infected. High rate of reoccurrence. Radiographic feature, the epicenter is located above the inferior alveolar canal, mandibular body, and ramus area. Well-defined cortex, secondary infection may result in the loss of the cortical margin, may have scalloped border. Internal structure is radiolucent with multilocular appearance in some instances. Its ability to grow along the internal aspect of the jaw, causing minimal expansion which delay its early detection. Can displace and resort the teeth and cause inferior displacement of the inferior dental canal. Histological feature, the cyst may contain a clear liquid that is similar to transudate of serum, or it may be filled with cheesy material. Stratified squamous epithelium, the epithelium and connective tissue interference is usually flat. Now for the periapical cemental dysplasia in early stage, clinical feature, middle age, teeth are vital, most common in the lower anterior teeth, There is no pain discovered by routine X-ray. Radiographic feature at the apex of the tooth or over the apical third of the teeth, most seen in mandibular anterior teeth, well-defined radiolucent border surrounded by sclerotic bone. It depends on the maturation of the lesion. We have 3 stages, and in our case, in the first stage, it is radiolucent at the apex of the tooth with loss of the lamina dura. Hypercementosis of the affected teeth, expansion of the bone may occur. Histological feature, cellular fibrovascular connective tissue with scattered hemorrhage and a variable mixture of woven bone, lamellar bone, and cementum-like particles. Now, simple bone cyst, clinical feature, very common lesion, second decay of life with male preference, mandible more than the maxilla, asymptomatic in most cases. Expansion of the bone is unusual. Aspiration yield straw-colored fluid. Radiographic feature in the mandible in the posterior region, well-defined to ill-defined, sometimes scalloped upper border. Totally radiolucent, sometimes multilocular, although it does not contain true septae. In most instances, it does not have an effect. Histological feature, no epithelial lining. The walls of the defects are lined by a thin band of vascular fibrous connective tissue. Fibrin, scattered erythrocytes, giant cells, and dystrophic calcification are found.
Hello, I'm Wujdan. I'm gonna talk about the histopathological. The cavity cyst was lined by the non-keratinized stratified squamous epithelium with mixed inflammatory infiltration present. Roshan high-lined bodies, which are amorphic and eosinophilic, liner to the crescent-shaped bodies in the cyst epithelium. It's present in 10% of the preapical cyst. Scattered ciliated cell, cholesterol cleft in the cyst lining. Case analysis, definitive diagnosis is radicular cyst. The management of the radicular cyst may include the surgical or a nurse-surgical treatment. Example may include extraction, endotherapy, and apical surgery. When they are a large, radicular cyst will be due a surgical removal or marsupialization. Marsupialization is a surgical technique of the cutting a slit into the abscess or the site or the cyst and the suturing the edge of the slit from a continuous surface from the exterior surface to the interior surface of the cyst abscess. The reference, thank you.